Right, afternoon, guys. I hope you guys are okay. Welcome back to the bootcamp series of mocks, and sorry for the late start today. I'm sure most of you know me by now. My name's Miet. I'm a cardiac surgeon in London, and currently finished my PhD at the moment at the Imperial College London as well. So I'll be a mock examiner. Today we're going to do two stations like in the real exam. So it's going to be about 10 minutes each for the particular station. So like in the exam, the first minute you're going to read the candidate instructions shown on the screen, and the remaining 9 minutes you're going to spend inside the station. There will be a 6-minute bell, and then if you're taking a history examination, then you have to stop at that 6 minutes, and the remaining 3 minutes I'll ask you the questions. All right, and then we will go through the stations together once we're done with that. And then we'll do the same pattern for the second station as well. So for the purpose of the mock, I need two volunteers. I can see Pradia's already raised hand, so that's going to be the one. So I need one more volunteer. That while we're waiting, this is our website, mrcsbootcamp.com. I'm sure you know about this, and please feel free to have a look around Telegram, WhatsApp groups, where we send out these mock links, Facebook page, and groups as well. Right, so one more volunteer, and then we can start the mock. Anyone? So again, so I usually say this is your chance to make mistakes, not in the exam. Right. And this is I can tell you this would be the most valuable experience that you're going to have for the exams. Great. So Somia, you'll do the second station. So thanks for volunteer. I can see a couple more, but we'll do another time. All right. Right here. Just gonna write it down. I do apologize if I pronounce your names incorrectly. Great. So for the purpose of the mock, I'm going to disable the mic throughout the mock, and then I'll let you mute it towards the end of the mock as well. Right. So just so Pratik, can you confirm you can talk now?
Yes.
All right. I'm gonna set the timer. Here we go. All right. So before we move on, can you tell me which bones make up the shoulder girdle?
Scapula, glenoid of the scapula, and head of humerus.
Head of
Humerus.
humerus. Okay. And what is the bony attachment? Tell me a joint between the upper limb and the trunk.
The scapulothoracic joint. The glenohumeral joint. Then uh, coracoclavicular joint. Then clavicular to the rib cage.
Just tell me one joint. Which one is it?
Clavicular, claviculothoracic joint.
I'm afraid there is no clavicular thoracic joint.
Uh, Costoclavicular joint. I mean,
And what structures contribute to the shoulder stability?
the head of humerus and glenoid labrum, the rotator cuff muscles, the coracoclavicular ligaments, glenohumeral ligaments, and the the biceps tendon, which passes through uh, the bicipital groove.
Right. So which muscle is this?
Uh, this is infraspinatus,
This is?
supraspinatus.
This is?
Uh, no, that is supraspinatus. The above which is deltoid. This is deltoid.
This is deltoid. This is?
Supraspinatus.
And this one?
Uh, this is latissimus dorsi.
And this one?
Uh, teres teres minor.
And this, sorry, this one?
Uh, teres. This is teres minor. Below one is teres major.
And this one?
Uh, this is biceps. The no triceps. Medial head of triceps.
What are the rotator cuff muscles?
Supraspinatus, infraspinatus, teres minor, and subscapularis.
Tell me their origins and insertions.
Supraspinatus arises from the uh, spine of the scapula. Supraspinatus, infraspinatus, and teres minor, all three are inserted on the greater tuberosity of the humerus, and subscapularis is inserted into the lesser tuberosity of humerus. Uh, Supraspinatus is originated from the above the spinal groove of the scapula. Infraspinatus below the spinous process of the scapula. Teres minor from the medial border of the scapula. Subscapularis from the anterior border of the scapula, anterior surface of the scapula.
What are their nerve supply?
Supraspinatus is supplied by the upper scapular nerve. Infraspinatus is supplied by uh, the lower scapular nerve. Teres minor is supplied by the uh, axillary nerve. Then subscapularis is supplied by the lower subscapular nerve.
And which muscles participate in the action of abduction?
Deltoid and supraspinatus.
Anything else?
Abduction. Deltoid initiates the abduction, and supraspinatus and also serratus anterior.
Okay, so deltoid
For
initiates the abduction, so up to which degrees?
0 to 30 degree, and after 30 degree it's supraspinatus, then overhead abduction by serratus anterior.
Any other muscles?
Uh,
So tell me the origin and insertion of serratus anterior as well.
Serratus anterior originates from the medial border of the scapula, and also the upper six ribs, and it is inserted into the upper six ribs. Originates from the uh, medial border of the scapula.
Upper, right. And what is the innervation?
uh, Long thoracic nerve.
What is this?
Supraspinatus.
Or this one?
This is deltoid.
Tell me what is this?
Uh, this is biceps muscle. This is triceps muscle. It's short head of triceps. This is radial nerve.
This
This is
one?
long head of triceps.
So tell me what this is.
This is pronator teres.
No, I mean the nerve.
Medial nerve.
This one?
Ulnar nerve. I mean brachial nerve, which divides into medial nerve and ulnar.
Sorry, say that again. Brachial nerve dividing into
Uh, oh, this is ulnar nerve. Ulnar nerve. This is ulnar nerve. Ulnar nerve.
and which
No,
artery is it?
brachial artery.
Can you tell me the anatomy of the deltoid, the origin and insertion?
Deltoid originates from the C3 to C6 vertebrae, also from the uh, upper thoracic vertebrae, and uh, it's a fan-like muscle, and then it's inserted into the deltoid tuberosity of the humerus.
What's the innervation?
Uh, it's innervated by uh, axillary nerve.
Right. What is this?
Coracoid process of the scapula.
And which muscles attached to it? Oh, time's up.
Coracobrachialis.
Right, unfortunately, time's up. Okay. So let me quickly write down. So there are a few questions left. Before I forget, I'm just going to let you unmute all of you. So feel free to unmute your mics and jump in the discussion. All right, I'm going to enable the chat as well. Great. So before I move on for this, so I think there are quite a few things. For example, starting with these muscles, they're not quite right. Some of them are right, but many of them are not. And you kept saying the deltoid as the medial one. Medial one is not deltoid. Rather, what is this?
Trapezius.
Trapezius. All right. And this is not supraspinatus either.
Yeah.
So we'll talk about this later on as well. And muscle abduction are not quite correct. Deltoid does not start the the action abduction. Deltoid is the one carried on beyond about 15 degrees.
15%, 15 degree to 19 degrees.
90 degrees, yes, that's
Yeah.
correct. And then, for example, deltoid doesn't get their origin from the C3 to C6 or upper thoracic vertebrae. Again, that
Yes.
is deltoid is getting the spine.
Yeah.
And
Lateral end of the spine and lateral
So
to tail.
again, these muscles
Left.
origin insertion, these are a bit confusing, and you would need to review these again. And then this is not the posterior view, unfortunately. This is where the biceps brachii, these muscles removed, and then you would see this one because this one would continue as this one. So these are the muscles beneath the biceps brachii. We are still looking at the anterior part of the shoulder. You can see what is this?
Coracobrachialis, yeah.
Coracoid
You can see still the coracoid process here.
Coracoid process.
And then you can see this is
Long
head of
biceps.
long head
this
of
is the
biceps.
long head of the biceps. You can see it's the cut version of the long heads of the biceps as well. And you can see this root of the nerve. Again, this root of the nerve here as well. We'll talk about these as well. So in short, we'll go through these together. Right. So starting with, if I do that, what I'm going to do is the chat volume is very low. So can you hear me?
Yeah, we can hear you properly.
Okay. So sorry, just give me a minute. Just going to double check. Just going to double check the right. Seems all right. So I'm just gonna go back to this thing. This where the slides go. Right. So what I'm going to do is I'm just going to load up the shoulder, not the shoulder only. So we'll start with the question. So shoulder girdle, which bones make up the shoulder girdle? And I'll tell you, humerus is not part of it.
Scapula and the clavicle.
Scapula and the clavicle. Right. So that is also, shoulder girdle is also called pectoral girdle. So that is the only bones. The humerus, in fact, is not really counted part of the girdle. So if I ask you one joint connecting the upper limb to the trunk, one bony joint, which one would that be? Unfortunately, there is no
Clavicle,
the
sternoclavicular joint.
because costoclavicular joint, meaning clavicle would be connecting to a rib. In fact, clavicle doesn't connect to a rib.
Sternoclavicular joint.
It connects to the sternum. So sternoclavicular joint, very good. So sternoclavicular joint here, towards the axial line, it's the only bony joint connecting the upper part, upper limb to the body. But again, it plays very little role because it's a small joint, it's rarely movable. Majority of the movements are done at the shoulder joint, but shoulder joint's not. Right. So that comes to the next question. What contributes to the shoulder stability? What are the most important factors contributing to shoulder stability?
Yeah.
Rotator cuff
The-
muscles.
Cross-rotator cuff muscles combined with the ligaments and the glenoid labrum and the biceps tendon, that whole things together. Right. So shoulder girdle or pectoral girdle is formed by the scapula and the clavicle only, and the sternoclavicular joint is the only bony attachment to the upper limb, to the trunk. And the shoulder stability, as we said, these are maintained by all these structures, but mainly the rotator cuff muscles. Which muscles are termed rotator cuff muscles?
Supraspinatus.
Supraspinatus, teres
How's-
minor, and
That's
subscapularis.
vertebralis.
All right, let's go back to the picture and look. What is this?
Yeah, infraspinatus.
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 Yeah, trapezius.
Trapezius.
Very good. This
Trapezius.
is not supraspinatus. This is trapezius. This one is
Trapezius.
Supraspinatus.
supraspinatus.
Spinatus.
Deltoid.
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 Yeah, teres major.
Teres
Teres minor.
Minor.
Teres minor.
minor. Why? It goes to the greater tubercle. This is teres
Yeah.
major. This
Yeah.
is
Median.
Long head of tricep.
a triceps, long head of triceps. And this one is the cut version of
Deltoid.
deltoid. Very good. Great. So now we will, I'm not going to go through the rotator cuff muscles, origin and insertion, etc., because you can review them later on. But make sure all of the important muscles, you know, origin, insertion, innervation, action, and sometimes they rarely ask about the action and the blood supply, but sometimes they could ask you that as well. So supraspinatus, that comes from the supraspinous fossa to the greater tubercle, and infraspinatus, again, infraspinous fossa to greater tubercle, and the teres minor, it's not the medial border, by the way, Pradeep. It must be from towards the lateral border of the scapula, again, towards the greater tubercle as well. And then subscapularis goes to the lesser tubercle from the subscapularis fossa. So the next, talked about muscles of abduction. So starts with the supraspinatus for the first initial 15 degrees. From 15 degrees up to 90 degrees, it's deltoid. Beyond 90 degrees, which muscles do the abduction?
Yeah, trapezius and serratus anterior.
They rotate the scapula, trapezius, and the serratus anterior. So they will rotate the scapula and they will lift the arm beyond that as well. So these muscles are very important. So again, deltoid, trapezius, and then serratus anterior. So you need to know all these muscles. And one of the questions they kept asking about is if serratus anterior is innervated by the long thoracic nerve, if it gets injured or the long thoracic nerve palsy, what would you say?
Ring scapular.
And how would you
Scapular.
test it on the examination?
You ask the patient to push against the wall.
Ask the patient to push against the wall, you look from the back, and then you would see the winged scapula. Great. Then there is sometimes you can ask about the pectoralis major as well, and then the arm muscles. So we'll go back to the picture, then have a look at the arm muscles. So this one is
Biceps.
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 biceps brachii. There are two biceps in the body. What's the other biceps, by the way?
Biceps
femoris.
Biceps femoris.
Great. This is
the muscle.
Okay.
Lateral, musculocutaneous nerve, continuous lateral
Cutaneous branch of
nerve.
musculocutaneous nerve. Lateral
Great.
cutaneous nerve of
lateral
the
cutaneous
forearm.
branch of the musculocutaneous nerve. In fact, this is the only sensory innervation. So how would you describe the sensory innervation of musculocutaneous nerve?
Continuous as the lateral cutaneous nerve of forearm.
Aspect of the forearm.
Lateral half of the forearm. Very good. Great. And then if we are going to remove this muscle, then we'll see two more. So this one is,
Brachialis.
Brachialis.
and this one is,
Coracobrachialis.
and the nerve piercing through the coracobrachialis is
Yeah, it's musculocutaneous.
Musculocutaneous nerve.
musculocutaneous nerve as well. Great. So this must be,
Median nerve.
Great.
this is a
Median
median nerve. You will not usually see the ulnar nerve from the anterior projection. And
Yeah.
by the way, the brachial nerve does not divide into the radial and the ulnar nerves. All of these nerves, they arise from
Plexus.
brachial
Plexus,
plexus. There are lots of connections going in and out of the brachial plexus, and finally comes out with three main nerves. Right. So unlike the artery, which the brachial artery will further divide down into the radial and the ulnar artery, this is different. Right. Great. And then we've got the scapula. So this one is
Coracoid process.
coracoid process. Tell me which
process.
muscles attach to the coracoid process.
Coracobrachialis.
And
Pectoralis minor and
Short head of
long head of
biceps. Brachialis.
Short head.
Short head of biceps.
Right,
I
right.
think.
So short head of the biceps, coracobrachialis, and the pectoralis minor. That's great. Oh. And one more question is, if the radial nerve is damaged in the groove while going through the groove, what would be the sensory loss?
root of the thumb.
Posterior part of the forearm and hand.
So which part will be spared?
The arm, posterior part of the arm will be spared.
Posterior part of the arm will be spared because before the radial nerve goes into the groove, usually
It already gives off the cutaneous nerve to the arm.
Great. So posterior part, lower half of the posterior aspect of the arm will be spared, and upper half of the posterior aspect of the arm, is it innervated by which nerve?
Axillary.
Are you asking me or are you telling me?
Yeah, it's axillary. Yeah.
It's axillary nerve. That's correct. So that is something we call is regimental.
Regimental area.
Regimental batch area is not here, by the way. All right, this one is not the badge. This is the rank badge. This is the regiment badge. So in the army, if you would like to know which branch that guy's from, then you look at the regimental badge, because this is the rank. Rank's nothing to it. So this is a suprascapular nerve. This is innervated by suprascapular nerve. Usually the root value is
Anterior rami of the C1.
C1 is too
C-
high.
The
C,
5'6".
C3, 4, 5 usually. Right, and that is the same as the root value of
Yeah, the
Phrenic
phrenic nerve.
Phrenic nerve.
phrenic nerve. So if phrenic nerve is innervated or the diaphragm's innervated, where would it refer the shoulder? What would the pain's going to be referred to the shoulder?
Lower body of the neck.
So usually it's on the shoulder or the root of the neck. Yes. So that is the referred pain. On the left, if something wrong with the spleen, for example, lower surface of the diaphragm could be irritated because of the splenic infarct, splenic injury, then it would be referred to the left. If on the right, for example, polycystitis, right, referred pain of the shoulder to the right as well. Great. And last bit, In fact, these notes are for 2 stations, so I'm not going to go through these again. But the last bit is the ulnar nerve injury. If the ulnar nerve is injured at the wrist versus at the elbow, which one will appear more clawing of the hand?
Yeah, it's
At the
the
wrist.
There'll be more
the distal,
chlorine at the wrist.
the distal will be more clawing.
Why is that?
It's called the ulnar paradox because of the flexor digitorum profundus will be spared.
Is it only flexor digitorum profundus, or is there any
Flexor
other?
carpi ulnaris.
Don't forget the flexor carpi ulnaris, right? For the purpose of the exam, it's important. In reality, flexor digitorum profundus is the main guy who leads the heavy walks. Right, that's correct. So if the nerve is injured at the elbow, for example, cubital tunnel syndrome versus Guy's canal injury, so the injury at the wrist will spare the ulnar half of the flexor digitorum profundus and flexor carpi ulnaris, which will cause more clawing of the hand. This is called ulnar paradox because when we look at the neurological injuries, the more proximal the injury goes, the more severe clinical signs that we see. But with the ulnar nerve, the more proximal we go, there is less clawing of the hand, which is not what we expect. And that is why it's called ulnar paradox as well. Which thumb movement will be affected with the ulnar nerve palsy?
Sorry, again.
Flexion.
Movement.
Adduction.
Abduction of the thumb movement will be affected because it
Adduction.
is innervated by the deep branch of the ulnar nerve.
On
Great. So that is pretty much it. Any questions? This is a very straightforward shoulder anatomy station. So the important thing is make sure you know the origin, insertion, innervations of the important muscles around the shoulder, rotator cuffs, and the pectoralis major and chest wall muscles in short. And then ulnar paradox, and then mechanisms of, the muscles of abduction and the other mechanisms. Great. Any questions? All right, if not, we're going to proceed to the next station. So again, I'm going to mute all of you again, and I'll let you unmute towards the end of the station again. So while we offer subscriptions, if you want to join us, please come and join us as well. We sit down and talk all through the stations like this one. And we have got London on-site course coming up, not this weekend. Sorry, the next weekend. Yes, we're coming towards the end of the April. So next weekend, the first weekend of May. So that's going to be at the London Heathrow Marriott Hotel. So I think 1 or 2 seats left. I'm not sure. So please come and join us if you're interested. We don't accept, once the seats are gone, that's gone. Right, what usually happens, so many people come and say, I want to attend this and that as well. And I'm afraid I can't run the second course either because of my availability and stuff. Now, if you're taking the exam in the UK this May, please feel free to come and join me. So the second station's going to do by Dr. Sumia.
Hi.
You ready?
Yeah.
There you go. All right, I will be your patient.
Okay.
We can start now.
Can I start? Hi, I'm Soumya. I'm one of the surgical doctors. Could you tell me a bit about what brought you in today, please?
Oh, doctor, I'm a bit embarrassed to say, but I've been a bit of having problems performing well sexually.
Hmm. Okay, there's no reason to be embarrassed, but do you mind if we go into a bit more detail about this today?
Oh, please.
So, when did this start?
I must have been about 6 months now.
6 months ago. Okay. And are you having trouble both with erections and ejaculations, or just one?
Just one.
Which one?
So I'm having a bit of maintaining erection.
Maintain. Okay. And have you noted, did this start with any sort of trauma or, out of the blue, or was it sort of a gradual thing that you noticed?
Well, a lot of things happened around 6 months ago, I must say,
Mhm.
because I lost my job and my wife left me, and then
Mhm.
I got diagnosed with the high blood pressure,
Mhm.
diabetes, cholesterol, and everything. I think a lot of the reasons, a lot of things
Mm.
happened around 6 months, and I'm not sure which caused it.
Yeah, so it's been a lot on your plate, I guess. Sorry about that. So you said that you were diagnosed with diabetes and hypertension. Are you on any medications for these?
Yes, I'm taking what the GP prescribed, but I can't
What the
really
GP is.
recall which medications
Okay.
yet.
Okay, no problem. Have you noticed any changes? Have your symptoms been getting any better or worse in the last 6 months since you've started taking these medications?
Well, I think more or less the same.
More or less the same.
Well, in terms of the erectile, sorry, beg your pardon. Instead, problem with the erection, it's getting
Mhm.
slightly worse and worse day by day. But in
Getting
terms of
worse.
the high
Okay.
blood pressure and diabetes, I think I'm okay.
Okay. Fine. Have you noticed any changes in terms of your general body status? Have you gained any weight, lost any weight?
No, I haven't noticed any.
No. Okay. Have you noticed what we call gynecomastia? So any enlargement in the breasts?
No, doctor.
No. Okay. Have you noticed any general sensations of feeling quite cold in your fingertips and toes or anything like that?
Not that I'm aware of.
Not that you're aware of. Okay. And just a couple of more personal questions for you, if that's okay.
Please.
Are you able to still get morning erections?
Oh, I'm not sure.
You're not sure. Okay. And in terms of ejaculation, are you still able to, or not really?
Sometimes yes, sometimes no.
Okay. Okay. And have you had any problems with urination? Having to get up in the middle of the night to go to the bathroom, or having the urge to go many times during the day?
Nothing as such.
Nothing as such. Okay. Is there anything else that you would like to tell me about, or anything that's worrying you?
No. Well, I've got a lot on my plate, and I'd really like to have this sorted because it's kind of like affecting my social life, and I don't
Absolutely.
want to carry on like this.
Yeah,
Honestly.
absolutely. I think we'll have to do a few more tests and possibly refer you to the urology team, but I'm sure that we can, come up with the reason for why this is happening and get you sorted.
Okay. All right. Thank you, doctor. So, are you ready to summarize the findings?
Yeah, so we've got a 60-year-old gentleman here who's come in with a 6-month history of erectile dysfunction, basically. So mostly in maintenance of erections, but also in ejaculation. He's had a pretty stressful 6 months, but he's also been emotionally, but he's also been diagnosed with diabetes, hypertension, hypercholesterolemia. We're not really sure if he's still able to maintain or if he's still able to get morning erections, but I think my diagnosis is leading more into the neuropathy type of erectile dysfunction due to his diabetes, but it could also be microvascular changes from his hypertension.
Or how about the other things like he lost a job and his
And
wife
the
left him?
psychosomatic, yeah, absolutely. And the psychosomatic aspect of that definitely makes a big difference. So that is well within my differentials as well.
Right. And which investigations would you like to do?
So in the first instance, I'd like to take some blood. So that's including the PSA and testosterone levels, and possibly perform a digital rectal exam to have a look at the prostate as well. And
Any other
HbA1c
blood
to
tests that
see
you'd like
how,
to do?
yeah, so HbA1c as well, just to see how his diabetes is being controlled, as well as his lipids, so his cholesterol levels. He mentioned that he's got hypercholesterolemia.
Anything else?
Following this, I would like to think about his hypertension, so possibly do 24-hour blood pressure monitoring as well to see if his hypertension is being controlled.
Anything else?
I think those are the initial investigations that I would go with.
Any particular investigation towards the erectile dysfunction that you'd like to do?
So I would definitely have a look at the testosterone and PSA levels.
In addition to what you said.
In addition to that, I'm not entirely sure.
How would you manage this patient?
So managing this patient, I would start by getting his sort of comorbidities under control. So diabetes, hypertension, and hypercholesterolemia. I would suggest with the patient, if he would like to speak to someone about all of the stress that he's had in the last 6 months. So for example, losing his job and his wife leaving him are very emotional triggers that could lead to erectile dysfunction as well. So possibly seeing a therapist or a counselor in that sense might help as well. And then we can also move on to specific drugs for the erections. So for example, sildenafil, Viagra, things like that.
So what is Viagra?
I think Viagra is sildenafil actually.
Silder?
Silfedenil or sildenafil? I think it's silfedenil.
Okay. How does it work?
It's a vasodilator, essentially. So it allows for blood to rush into the penis to allow the patient to, one, get an erection and maintain an erection for a longer period of time.
And how does it cause vasodilatation?
It's it stimulates it prolongs the action of nitrous oxide, which is a vasodilatory agent.
What is the mechanism of action? So what does it do exactly?
So the mechanism of action would be relaxation of the vessel walls through the action of nitrous oxide.
So let me give you a hint. Which enzyme does it block? That's my question.
CGM.
Right.
No.
Okay, it's not
No,
cyclic
I'll
GMP
stop.
or cyclic AMPs. So the next, what would you like to do? Anything else? Let's say the patient's not getting better. Anything else you'd like to step them up to?
Would I, in this situation, am I allowed to say that I would have to refer him to urology?
Yeah, you can.
Okay, yeah, so I would definitely refer him to urology.
The next question would be, what would urology give him?
There's some surgical techniques which can also be used in erectile dysfunction. I think one of them is a sort of prosthetic balloon pump that you can use.
Okay.
Which is obviously quite invasive for the patient, but depending on their choices might be worthwhile.
Any other medical kind of like options?
Testosterone supplements.
What? Well, testosterone supplements would work if the patient's got hypogonadism, but otherwise, probably not.
Otherwise, no. Yeah.
So we'll talk about this. Before I forget, I'm just going to unmute all of you. Feel free to unmute your mic and then jump in the discussion, right? And right. So Sumaya, what was the name of the patient that you talked to?
I didn't write that down.
You didn't ask. Right. You
No,
didn't
I didn't
ask
ask.
at all,
No.
unfortunately.
Yeah.
So very important, you have to identify
Yeah.
the patient. You did introduce yourself, identify the patient as well. I do recommend you wash your hands. Well, you don't wash your hands, just gel your hands in the exam as well. That's usually about 1 mark as well. And then there are particular histories that we would need to ask. So you finished the history 2 minutes early. So your speaking speed is good.
Okay.
That's really good. And that kind of like tilts the favors towards you as well, because everybody speaks it differently at different rates. But we only get 6 minutes to talk, right?
Mhm.
So you're not rushing, but you are towards a little bit faster side of the spectrum, so which is good.
Mhm.
But the problem is that if you finish 2 minutes early, there are two things. You're either really practiced well, you're really good with history taking, or you've skipped a few important things. Fortunately, in this case, the letter. So for example, sexual history. We need to know the sexual history of the patients. Is he sexually active now? How many partners has he got? And does he use protections, etc., etc.? And secondly, psychological history. Do you think it's important? It's important as well. So because the patient's recently lost the job and the wife left, etc., etc.
Yeah.
So to get maximum marks in these stations, we have to demonstrate asking a few more questions from these two aspects as well. I think that's what you skipped one. And management investigations and the management, we'll talk about it later on, right? PDE5 inhibitor as the word I was looking for. It's a sildenafil. Right?
Yeah.
It's not sildenafil, it's sildenafil.
Sildenafil, yeah.
All right. So the examiners are like predators, right? They will prey on you, and if you're not sure if there is any hint or sign, they will press on it, and then they'll catch it. Right. What I'm going to do is I'm going to load up the notes, and then we'll quickly go through this together. Oh no, not atrial fibrillation. You're right. Oh, dysfunction. Great. So start the history, go in, wash your hands, introduce yourself, identify the patient, take the consent, and then presenting complaint. In this case, we're going to deal with the erectile dysfunction. So it's very important that we ask about the onset, because if it started suddenly versus gradually, if I'm to simplify things, if there are two things that you're going to see with the onset in the history stations. If it started suddenly, your next question should be what happened at that time, because there almost always is an event that triggered it. Nothing starts suddenly, right? So if normally the trajectory or the natural history of the diseases is the gradual. So in the history stations, my advice to you is if the patient tells you, okay, start suddenly, next question you should ask is what happened around that time. Secondly, the natural history has been going gradual, and then all of a sudden at one point, the disease changed the course of the natural history. For example, let's say BPH, that's very common with the BPH history station as well. So the patient's been having this problem for the last 5 years, and the last 2 weeks or 3 weeks, the symptoms got a lot worse. The next question, again, your question should be what happened around that time as well, because there is another trigger factor that changed the course of the disease. So every time there is a sudden change in the course of the disease, you have to dig it up, and that's a job, and to demonstrate to the examiner to get the marks in the exam. So the next, duration, progression, is it getting better? Is it getting worse? Predisposing event, again, if the patient didn't mention about it, then you could ask, okay, what happened before it started, what's caused this one, and then anything makes it better or anything makes it worse as well. And make sure during the history you don't use the medical jargon. Very, very important, because if well, let me remind you the marking scheme of the history stations as well. So 12 marks will be from the medical side and the 8 marks from the communications and professionalism side, meaning communications got 4 marks. If you keep using medical jargons, or if the patient didn't seem to understand and you just ignored it and moved on, then you're going to lose 4 marks, even if you take a perfect history. And if you don't pay attention to, let's say, patients talking about the difficulties in the erections and stuff, and then you didn't demonstrate any sympathy and empathy, again, you're going to lose another 4 marks. So that is 8 out of 20, even if you take a perfect history. So that's why these are very important for you to pay attention as well. Don't use the medical jargon, be sympathetic, be kind all the time. Well, then the next thing, we need to quantify what he means by erectile dysfunction. Is it difficulty obtaining an erection, or is it maintaining penetration? Does it ejaculate? Does it happen, or does it not happen at all? Or sometimes yes, sometimes no. Sexual satisfaction, does both partners have got sexual satisfaction or not? And the morning or the nocturnal erections. Again, this is a very, very important, again, for the purpose of the exam, it's more important. So if something's happening overnight, then there is a somatic problem. Meaning, if there is erectile dysfunction happening overnight, meaning the patient is not getting any morning erections or the nocturnal erections, what do you think is the cause? What is happening?
Likely hormonal if there's no morning erections.
Somatic, could be
Organ.
hormonal, could be structural, kind of like
Yeah.
damage to the nerves and the arteries as well. But
Yeah.
there is something actually going on with the body compared to the somatic, compared to the psychological things. If the
Right.
patient's erectile dysfunction is mainly triggered and driven by the psychological causes, then the patient will still have the nocturnal and the morning erections as well. One of the other more prominent examples I give is irritable bowel syndrome versus inflammatory bowel disease. In the inflammatory bowel disease, there is a somatic problem. There's an actual problem with the bowel, so the patients have to get up at night to go to the toilet. Where irritable bowel syndrome, they rarely have to get up at night because irritable bowel syndrome, a large component is driven by the psychological factors as well. And we're going to ask about the pain, discomfort, any structural deviations like penile curvature, is it normal or not? And then we can ask about the genitourinary system, especially the dysuria. Got any burning sensation when you go to the loo? And frequency, how do you ask about the frequency?
So, how many times a day do you urinate? Do you find yourself having to rush to the toilet?
So if the patient tells you, okay, I go to the loo 4 times a day, 5 times a day.
Yeah.
What does that mean? Is it too much?
Are you passing urine? It depends if it's
Is this the normal to you?
Yeah.
So what I would recommend is just ask, do you have to go to the loo more often? Because you can't really ask how many times because different people go to the loo different times, right? But if the patient tells you I have to go to the loo more often than usual, then that is the you demonstrate the frequency as well. So frequency, urgency, nocturia, and hematuria is the malignancy sign that we have to ask and demonstrate. And then we can ask about the sexual history. Are you sexually active at the moment? And the last sexual history, one was that, and how many partners have you called, and who are any use of protection or not. And normally, if I would normally go back a few months from the previous sexual contact as well. So if the last sexual contact, let's say about 6 months ago, then I would go back about 9 months or even a year, and then ask about if there was any problem with that. The next is a psychological history. So any episodes of low mood, insomnia, lethargy, any loss of libido. Again, loss of libido and erectile dysfunction. That's one thing. Versus high libido and erectile dysfunction. That's another thing as well. So loss of libido and erectile dysfunction. What do you think the cause is?
Psychological.
Loss of libido and erectile dysfunction versus high libido and erectile dysfunction.
Hormonal.
So loss of libido and erectile dysfunction could be one, psychologically driven causes or the hormonal causes. So hormonal causes will suppress the libido. Like, what kind of hormonal cause am I talking about?
Yeah, prolactinemia.
Prolactinomas, right? That is the most common pituitary tumors. More than half of them are, more than half of the pituitary tumors prolactinomas. So prolactinomas and stuff. On the other hand, high libido and erectile dysfunction, meaning there is an actual somatic problem. The patient has got intact libido, but they cannot perform because of some form of somatic disease, like vessels or the nerve damage, maybe due to diabetes. Problems with tension in a sexual relationship, any stress from work and other sources as well. And then remaining, well, we usually ask the same things, right? Past medical history, past surgical history, family history, social, drug, and ice as well. So if I'm to recap the scenario, the patient comes to you, it started about 6 months ago, and lots of things happened around 6 months ago as well. You got diagnosed with diabetes, you got diagnosed with hypertension, high cholesterol, his wife left, he lost a job, and all of these things probably triggered this one. So we now have got a complete picture. The next thing is investigation. Which investigations are we going to do?
Hormonal assay.
Such as?
Prolactin, TSH, and free T3 and T4 for the thyroid functions. LH and FSH for the testosterone assessment as well.
Okay. Anything else?
You want to do a duplex?
Growth hormone, yes, as well, because the because of the pituitary adenoma might produce a growth hormone.
Right. Anything else? Any other investigations that you'd like to do?
Yeah. Full blood count. Yeah, of course. High profile, lipid profile, and the routine labs for if the patient is might be anemic as well.
Okay. Anything else?
Duplex ultrasonography to assess
What is
the
duplex?
Yes, it's a B mode ultrasonography scan for vascular function of the penis.
B mode is different and the duplex is different. So what's the difference between the B mode and the duplex?
I think the Doppler plus
duplex color mode.
I can't.
Right. Okay, we'll talk about it. Right. Anything else?
Yeah, we can assess the cardiac functions by echo, ECG.
Why do you want to do the cardiac functions in the
Yeah,
case of
but
erectile dysfunction?
the patient is maybe his comorbid conditions might affect the if the patient is
But
really
does he have a heart disease?
yeah, he's hypertensive.
But
Or
does it mean he's got a heart disease?
no.
So if there is no proven coronary artery disease, even the mild ones, you don't necessarily need an echo, by the way, right? So examiners will push you further and then start giving you a hard time. So by the way, the rule is if you say the investigation, if the examiner stops you and then asks, okay, why do you want to do this? You must be able to defend it, right? Or rather you rather not say it from the very beginning as well. So why don't we go through the investigation together? So that is pretty much complete. And if we want to go one step further, then there will be a DSA as well. So you can start with the questionnaire, like in the, well, there are two urology history stations in the MRCS exam. One is the BPH, the other one is the erectile dysfunction. So both of them, you can start talking about the questionnaire. So for the BPH, what do we use?
Oh, sorry. BPH, microscopic make tutorial gateway. Oh god, I'm mixing this shit
So
up.
what's the name of the questionnaire we use?
International Prostate Symptom Score.
IPSS. International Prostate
IPPS score, system scoring system.
Right, International Prostate Symptom Score.
International Prostate Scoring System.
Symptom score is the other way around, if I'm not wrong.
Score, okay.
So make sure you know the longer forms of these as well. So here is IEF 15. This is the 15 questionnaire for the International Index of Erectile Function as well. So the use of this questionnaire is, these are very subjective symptoms and you want to objectify it, at least to a certain extent, by using these questions as well. And then we're going to do the routine blood test, full blood count using a CRP, L3 safe, then additional blood test, lipid profile, HbA1c, PSA, potent, thyroid function test, testosterone, FSH, LH, and prolactin as well. Do not forget the prolactin. And then we do need to screen for urinary tract infections as well. So urinalysis, if positive, then we can send for the urine MCNS as well, and the penile arterial duplex. So now comes to the point, what is duplex? Duplex is
a non-invasive imaging test. It involves the use of the B mode ultrasound and the Doppler. And what the B mode does is to image the structure of the vessel. And the Doppler measures the speed and direction of blood flow.
Great. So B mode, which is the 2D ultrasound, you just grab a simple ultrasound, put it on the skin, for example. There you go, that's a B mode. And the Doppler. Doppler is the Hendel Doppler, as we all know, that is a true Doppler. True Dopplers do not give you any of the visual things and stuff, it gives you the signal. So the Doppler effect is, imagine you're standing next to a train track and the train passes by and blasting a horn, for example, you'll hear the horn getting louder and louder, loudest nearest to you, and then fades away. That is something called Doppler effect. You can use the same effect and apply that to the probe, and the blood flows through the probe, and that is how the probe picks up the Doppler. Right. Next, what we can do is, for example, if the actual blood flow is flowing towards the probe, we can paint it red. And if the flow is flowing away from the probe, then we can paint it blue. And that's how you see the red as the arteries and the blue as the veins on the Doppler as well. So duplex is, in fact, 2D, 2D mode, which is the B mode, plus Doppler. Right. So that is the arterial duplex, and duplex is usually superior to the angiograms in a way that, why, by the way? Why would duplex usually be superior to the CT? Anyone?
It's a more dynamic study.
It's a physiological study, whereas the CT scan is anatomical study. What I mean by anatomical study is that in the CT scan, the contrast passes through, it takes a picture, that's it. For that a fraction of a second, you are seeing the picture there. Whereas the duplex, it's a continuous functional assessment. You can see the flow into it, you can calculate the indexes, you can calculate the pressure, you can estimate the volume, you can do pretty much everything with the duplex inside it. Right? So that's why duplex are usually superior for the vascular structures, both the artery and the vein. So for the purpose of the exam, if it's a vessel, it's a duplex. You can keep that in mind. And the CT angiogram, one of the main things about the CT angiograms is that it's readily available. Duplex is not, because duplex is usually done by vascular scientists. It's not all the radiologists can do the duplex scan. So it's not readily available. It's definitely not available out of hours most of the time. However, CT is available all the time, and the CT is quite quick as well. Plus, CT can show you the whole anatomy of the limb in one go. Right, if required, penile angiogram would be the next step. That's a DSA, digital subtraction angiogram. This is both diagnostic as well as therapeutic as well. So that comes to the next question. What's the management? What's the management of erectile dysfunction? Anyone?
Manage the underlying cause.
Okay, such as, give an example.
If it were hormonal prolactinoma, you would want to either medically or surgically manage the hormonal cause. If it was diabetes, for example, you would want to give some sildenafil citrate. If it was caused by the prostate, like BPH, you would BPH not really cause erectile dysfunction, but it was caused by the prostate, you want to give tamsulosin, dutasteride, medical management, or a prostatectomy.
Okay, well, we've treated an aligned disease. What's next?
For this patient, psychiatric evaluation would help.
Psychiatric evaluation may not always be necessary, but counseling. So who do you refer the patient to? Counseling is not usually done by a psychiatrist. Brother?
Psychologist.
Psychologist. Right, psychologist, the difference is psychologists may not have a medical background. They may not be the doctors, right? But psychiatrists, they are always the doctors. Great. So, for example, if we're going to focus towards the past history of, let's say, the patient's lost a job and the other things, then we can we can refer the patient to the CBT. That's a cognitive behavioral therapy, which is usually the first line. Or if we're going to focus on to the erectile dysfunction now, that the issues are relatively resolved and we want to focus on this one, then there are psychologists who kind of like specializes in the sexual part of the field. So we can refer to the psychosexual counseling therapy as well. What's next? So sildenafil. What is sildenafil?
Phosphodiesterase inhibitor.
PDE5 inhibitors. They're very important because they will always ask you about it. And then one more question. Where else do you use the sildenafil?
Pulmonary hypertension.
Pulmonary hypertension. Right, because it's a very potent vasodilator. And if there is pulmonary hypertension, then we can use it to dilate the pulmonary vasculature as well. Great. Not getting better. What's next? What are the other options?
Surgical options.
Let's quickly go through this one.
Use of intracavernosa injection.
Yes. So we'll go through this together. Right. So urology MDT started lifestyle modifications. By the way, what are lifestyle modifications?
Smoking cessation, alcohol, maybe modification,
so
exercise.
It's a general question, not to the erectile dysfunction. How would you answer lifestyle modifications? Sometimes the examiner could stop you. Okay, tell me what are lifestyle modifications? How would you answer these to them?
Supervised exercise if the patient is comorbid.
So, for example, lifestyle modifications for carpal tunnel is very much different from lifestyle modifications for erectile dysfunction. Am I correct? So how would you answer the lifestyle modifications question? You should think of the risk factors or the causes. Either the causes or the risk factors, pretty much these overlap a lot. So when you answer these lifestyle modification questions, think of the risk factors or the causes that drives the disease process, and you need to modify them. Some of them are modifiable, some of them are non-modifiable, like age, for example, gender. These are not modifiable genetics, but a lot of them are modifiable. That's why you would, when you say lifestyle modifications, smoking cessations and the alcohol reduction that comes to your mind. Right. Next, psychosexual counseling therapy, talked about it. And then the next step is the medical. So medical is the first line, is usually sildenafil, and it's a PDE5 inhibitors. It's a very potent vasodilator, causing relaxation of the smooth muscles and vasodilatation of the vessels. The next step, if we're going to do it, is one intraurethral suppository. This is kind of like putting the gel in when you're putting the urinary catheter in. Instead of the gel, what we inject is the L-prostadil, which is a synthetic prostaglandin E1, or you can directly inject into the intracavernous injection of the L-prostadil as well. And then the surgical, before the surgical, there are vacuum erection assisted devices or VEDs. These are the external devices that the patient uses to help them get the proper erection. And lastly, penile prostheses implantations. These are the invasive options, and the urologist will deal with this. Great. And then the causes. What's the most common cause of erectile dysfunction, by the way?
Diabetes.
Diabetes.
Psychological.
Diabetes, not like psychological, I'm afraid. So diabetes, because diabetes is a nasty disease, it will affect both the nerves and the vessels. And both nerves and vessels are very important with the erectile erection function. So diabetes is the most common one. And before I open this up, so this patient, there are a lot of the potential causes that we talked about it, like psychological. There's the patient's wife left and the patient's lost the job as well. And then he got diagnosed with the diabetes, hypertension, and high cholesterol. So that is, again, other possible causes as well. And one more thing that I would pay attention to for the purpose of the exam, particularly, in real life, it's a bit less common, but for the purpose of the exam, you need to ask what? What is another common cause of erectile dysfunction in patients who got newly diagnosed with hypertension? That's my hint to you. Newly diagnosis 6 months ago, hypertension.
Drug abuse.
What's the cause? Say again.
Stroke, cerebrovascular disease.
Well, it's too early with the 6 months to have a stroke.
Maybe
Well,
due to
not.
the drugs.
Drugs. What kind of drugs are we talking about?
Beta
blockers. All right.
Beta blocker.
Beta blockers, the most famous side effect is erectile dysfunction, but luckily that's not the most common. So for the causes, could be psychological, could be hormonal. A lot of things could be driven by hormonal pituitary dysfunction and the pituitary tumors, including pituitary adenomas, mostly prolactinomas, for example, or hypothyroidism as well. Hypogonadism, low testosterone, then you have to replace them. And vascular causes, hypertension, diabetes, high cholesterol, smoking, or previous radiotherapy in the groin, for example, prostate cancer. That's why it's important to ask about the prostate cancer, prostate problems, and if there's any treatment received. Neurological, spinal cord injury, diabetes, Parkinson, or the stroke that you just talked about, or in the injuries, pelvic fractures could affect the nerves as well. And the infection, I've got to ask you this one. And again, this is it's not a very common cause of the erectile dysfunction, but chlamydia can cause erectile dysfunction mainly through prostatitis and then causing erectile dysfunction. So in the exam, if they could ask, okay, what kind of sexually transmitted diseases can cause erectile dysfunction? This is your answer. And the drugs, antihypertensives, antidepressants, antacids, opioid, cocaine, some things, all these psychoactive drugs can lead to erectile dysfunction as well. But in the elderly, we would be focusing on the antihypertensives, and beta blockers are usually a culprit. Sometimes the patient could tell you, oh, doctor, yes, the GP started me on atenolol or something. I don't know. I started taking that medication 6 months ago. Well, there you go. So that's atenolol. Atenolol driving the erectile dysfunction as well. And erectile dysfunction is rarely the course is singular. It's usually a combination of all the things. Great. So that is pretty much of it. We got any questions?
Well, thank you.
All right. So if that's the case, I wish you rest of the good weekend, and hopefully we'll do another MOOC next week. All right. Take care.
Hello, sir. I have a question.
Go on. Go
on. I wanted to ask, do you recommend while is taking history in the exam to write on the notes?
Oh, that's a good question. So can you write during taking history? Will you be given paper and pen in the exam?
Yes, in the history, yeah.
The answer is yes. Should you write? I don't recommend it. Why? There are a few things. Well, as I said, history stations are marked 12 marks for your history taking and 8 marks for the communications and professionalism. So when you start writing things down, sometimes you would miss, you get disconnected from the patient and you won't be listening to what the patient's saying, or sometimes you might have ignored some things. So that if that's the case, you're going to lose some marks for it. And secondly, there are only about 3 to 5 positive findings in all the histories. So there's no point writing it down. If you, I'm sure you can remember 3 to 5 things throughout the history for 6 minutes, but if not, you can still write it down. So just to recap, do I recommend writing things down? The answer is no. Keep it in your mind, because to minimize the disruptions, and you only get about 6 minutes as well, especially if you're a slow writer or if you take time and you get disconnected from the patients. The interaction should be smooth and continuous, and you should always pay respect to the patient with sympathy and empathy. If you're trying to do multitasking, then you might start to miss things, and then you start to lose marks. So that's my answer. Any other questions? Great. If not, I'll see you hopefully next week. Thank you and bye-bye.